we know that airway starts from nose up to the smaller terminal bronchioles. Okay, this here also. So if there is narrowing of this airway, the airflow become more turbulent and a sound is produced. So mainly there are three sounds which are produced by the narrowing of the airway. So one is wheeze, which is seen in bronchial asthma, which is due to obstruction of the intrathoracic, the smaller airway, and the other two are stridor and also stertor. So today we will see what is stridor, how it differs from stertor, what are the types and the causes of stridor, and also the assessment and the treatment of stridor. Okay. So we know this is nose, nasopharynx, then a larynx, trachea, bronchi, and then the next divisions of bronchus. Please see the class on tracheobronchial tree, so you will get more idea on the lower airway. The stridor is produced by obstruction of airflow at or below the level of larynx. Okay, so stridor is actually, it's a high pitch noise, high pitch musical sound, and you can easily identify a patient with stridor when he or she reaches the door of ear. Okay, it's a high pitched musical sound produced by narrowing of airway at or below the level of larynx. Okay, at or below. And this has to be distinguished from another sound which is a stertor. Stertor is actually a low pitched snoring type of sound, low pitched snoring type. And the stertor is produced by narrowing of airway at the nose, nasopharynx, the oropharynx, or sometime by the supraglottic larynx. Okay, so above the level of larynx, we can broadly tell it as stertor happens above the level of larynx. It is low pitched, whereas the stridor is a high pitched musical sound by the obstruction of airway at or below the level of larynx. Okay. Most of you must have heard stridor when a patient of CA larynx or carcinoma larynx comes to emergency. And listen. So this is a high pitched musical sound which is very harsh and also having a grating quality, grating like quality. Okay, so high pitched sound, harsh and grating, and this can be inspiratory. What you now heard is an inspiratory stridor. This can be expiratory also. Expiratory and biphasic. Biphasic means it happens in both inspiration and expiration. So stridor is a high pitched musical sound which is very harsh in quality with a grating sound. It can be inspiratory, expiratory or biphasic. There is another classification which can be an acute or a chronic stridor. Whereas stertor is actually a low pitch sound and happening above the level of larynx. It is not that much dangerous as happening in a case of a stridor. So what are the causes of stertor and also the causes of inspiratory, expiratory and biphasic stridor? So all these are causes of stertor in neonates, children and adult. In infants, the whole thing become either it is a stertor or a stridor. Assessment and treatment is much more difficult because of the differences between an adult larynx and an infant larynx. So in neonate, The common causes are neonatal rhinitis or coronal artery stenosis, which can happen as congenital variety, craniofacial abnormalities, nasopharyngeal masses, especially in nasal and nasopharyngeal masses, and encephalocele, a nasal glioma, then meningocele, etc. And children, allergic rhinitis, adenoid or tonsillar hypertrophy, foreign body nose, etc. And in adult, all the causes which can lead to Stertor can also lead to an obstructive sleep apnea syndrome, which we can discuss later. Regarding OSCEs, we will discuss later. Okay. So in adult, the common causes of a Stertor are a septal deviation, then infections like Ludwig's angina or a retropharyngeal abscess or a parapharyngeal abscess, etc. Okay. And in Stridor, the causes are again a bit different because it happens at or below the level of larynx. So what are the causes of inspiratory stridor? So this inspiratory stridor happens in causes extrathoracic. Inspiratory stridor happens in extrathoracic causes. Okay, extrathoracic. The narrowing should be extrathoracic. According to Bernoulli's phenomena or Bernoulli's principle, when there is narrowing of the airway, two things happen. One, the air flowing through this become more turbulent, and also the intratracheal pressure falls below that of the atmospheric pressure. So there is a dynamic airway collapse. Here there is dynamic airway collapse happen. Okay, so the turbulent airflow along with the dynamic airway collapse will causes vibrations which are heard as sound, which is heard as an inspiratory stridor. In expiratory phase, this will not happen because of the positive airway pressure. The airway become open, so the sound will not happen. Okay, so inspiratory stridor is due to extrathoracic causes, and this is the reason of an inspiratory stridor. And the causes are, actually there are so many causes, but these are some of the commonest causes of inspiratory stridor. In neonate can be due to congenital causes or acquired, mainly congenital, mainly laryngomalacia or a vocal cord palsy, and acquired posterior laryngeal cleft or intubation traumas or laryngeal web, etc. And children, mainly croup or acute epiglottitis, hemangiomas, laryngeal papillomatosis, then arytenoid fixation, etc. And adult, the commonest cause being carcinoma larynx or infective like an acute epiglottitis, or granulomatous conditions like laryngeal tuberculosis, etc. And these are all due to inspiratory causes, but in expiratory stridor is mainly due to an intrathoracic cause. The cause will be inside the thoracic, that is mainly the trachea and also the main stem bronchus. So expiratory stridor is due to intrathoracic lesion, that is trachea or the main stem bronchus. Okay, and what happens here is the elevated pleural pressure will compress the airway at the time of expiration, so that there is stridor is produced at the time of expiration. And the causes are, in neonate, mainly the tracheal stenosis or vascular compression will cause an extra expiratory stridor. And in children, it can be foreign body or bacterial tracheitis or mediastinal tumors, etc. And in adult, tumors or infective pathology, or can be neurological disorders or idiopathic, then thoracic aortic aneurysms, etc. Anything which causes a compression or a lesion in the intrathoracic area, mainly the trachea and the main stem bronchus. And biphasic stridor occurs in a high or mid tracheal lesions. And children, it can be a cause, the subglottic stenosis can also be a cause of a biphasic stridor. Okay, So now you know the causes of inspiratory, expiratory and biphasic stridor, and it can happen all of a sudden as in an acute stridor. Mainly the acute stridor, the cause will be an infective pathology as it happening in an epiglottitis or a laryngotracheobronchitis, or it can be a chronic stridor, the commonest being in adult being the carcinoma larynx, okay, happening for a long period of time. And assessment start from history taking, physical examination and also some investigations. So in the assessment, as in always, the most important or one of the important thing is a very good history taking. So in children and in infants, you need a perinatal history, especially history of preterm labor and also the starting, the duration of stridor, okay. Because in dynamic obstructions like laryngomalacia, the stridor will happen within few weeks of delivery. But in case of a congenital vocal cord palsy, the stridor will happen immediately after delivery. So that should be noted. The second is pattern of stridor, whether it is inspiratory, expiratory, biphasic, or whether there is a diurnal variation. For example, cases like laryngomalacia, there won't be any stridor during rest, but when the child is irritated or crying, the stridor will be very much prominent. And also in cases of some pedungulated laryngeal masses like polyp or hemangioma, the stridor will be prominent when the child is lying supine. Okay, and the third is associated features like cough or dying spells or history of aspiration, hoarseness of voice as in laryngeal lesions, or whether there is an history of cough while at the time of feeding, etc. Associated features. Then feeding history, because feeding and respiration is very much connected, especially in infants. The breastfed infants will with the respiratory obstruction or airway obstruction will characteristically go for, they will come up for air, and also the bottle fed infants will prefer teats with a very small holes. That is important. Then general medical conditions like any neurological problem, if it is associated with the congenital vocal cord palsy, or whether there is a cardiac anomalies or any history of any cardiac surgery, all those has to be asked. And in acute obstruction, along with the resuscitative measures, ask for any history of any infective condition or foreign body aspiration. If it is in adult, ask for history of tobacco or alcohol dependence, any substance abuse or any other dependence. Then history of obstructive sleep apnea. That is the history of frequent waking in the during night hours or during sleep. Then excessive daytime sleepiness, intellectual deterioration, then history of tachypnea, shortness of breath, failure to complete a sentence, and failure to complete a sentence. That is also a very good indicator for any respiratory or airway problem. And also in both cases ask for history of drooling and also mental status. Okay, drooling and mental status. So all these should be asked in detail in history taking. After a thorough history taking, continue with the examination. Especially in children, first few minutes you observe the child. That is one, you can find out so many things and also you can gain confidence of the child. Okay. So basically in general examination, the body habitus, the facial features, especially look for any evidence of any syndrome. Then respiratory effort, chest recession, both you look for subcostal, intracostal and also the suprasternal recession of the chest, abnormal voice, wheeze, cough, etc. And after that examine the chest with stethoscope so that you can find out whether the stridor is inspiratory, expiratory, biphasic, or if there is any associated cardiac murmurs, etc. And then look for detailed nasal examination using anterior rhinoscopy. Especially in adult, look for any deviated nasal septum, nasal polyp, etc. Then oral cavity and oropharynx, especially in case of the floor of mouth, then the size of tongue, any hemangiomas, any mass lesions, etc. And also examination of neck is important. Next most important is investigations. In an acute stridor, oxygen saturation assessment will be sufficient. But in case of chronic cases, if you are giving oxygen, what happens is this carbon dioxide buildup will happen and there will be respiratory acidosis. So in that cases, a blood gas analysis will also be needed. Okay. Then in imaging, a plain chest X-ray along with the soft tissue neck lateral view. X-ray, soft tissue neck lateral view, but digital X-ray will be needed. That will be sufficient. Digital X-ray will be useful. The usual X-rays are not that much efficient, but digital X-ray will be a very useful thing. Then video fluoroscopy is an excellent tool in the diagnosis of an laryngomalacia. Then in CT scan, and also you need CT and MRI in some cases. But even if you are taking a CT scan and helical CT with multiplanar reconstruction will give very valuable results. Then you also need, in some cases you also need an echocardiography or an ultrasonography of the neck. And in very efficient hands, an ultrasound of the vocal cord will also be very useful. But you have to select the investigation according to the presentation and your provisional diagnosis. Okay. And next one is if it is an adult, you need a sleep study, especially in adult. Sleep study or polysomnography is for the formal diagnosis of an obstructive sleep apnea. Then assessment of gastroesophageal reflux. Then a pulmonary function test, and the gold standard in the assessment or diagnosis of stridor is endoscopy, whether in children or in adult, whether under local anesthesia or general anesthesia, a flexible or a rigid endoscopy of the airway that is needed for the confirmatory diagnosis of the cause of stridor. Okay, so these are the investigations in the diagnosis of or the assessment of stridor. The treatment of stridor depends upon the cause of the stridor, but in a case of acute emergency, acute airway obstruction, it is actually a multidisciplinary team approach. And along with the assessment of the airway, start with oxygen therapy, humidification of air especially in children, and also pharmacotherapy, that is first is securing a wide lumen cannula, then IV steroids, nebulization especially with budesonide, then racemic epinephrine 0.5 ml can be given especially in a case of home setting. Then if it is outside hospital setting and if you suspect choking, immediately give Heimlich maneuver, or if the patient is found unconscious with a respiratory obstruction, start on a BLS protocol till you wait for the ambulance to arrive. If it is in a hospital setting, always call for a cord alert, and in adult you can go with a cricothyroidotomy or a tracheostomy. And if it is children, even now the endotracheal intubation is, the evidence shows that endotracheal intubation is better than a tracheotomy, because in the child tracheotomy is very difficult than that in the adult. So we always prefer an endotracheal intubation. And in case of chronic airway obstruction in adult is mainly due to obstructive sleep apnea, that we will discuss later. And in children, the chronic airway obstruction is mainly due to adenoid hypertrophy or tonsillar hypertrophy, or any deviated nasal septum, or any causes in the mass lesions in the nasopharynx. So that has to be treated accordingly. We discussed about what is stridor. We heard how the inspiratory stridor and biphasic stridor, then the causes and also the assessment methods and also the treatment.